Assalamu alaikum doctors. Today we will be discussing about the secondary amenorrhea. So what is secondary amenorrhea? Actually it is a condition in which there is absence of menstruation for 3 menstrual cycle. It means females early menstruating normally, but from the past 3 cycles she is not menstruating. So this is called as secondary amenorrhea. What is secondary amenorrhea? It is a condition in which there is absence of menstruation for 3 menstrual cycles. It means females early menstruating normally, but from past 3 cycles she is not menstruating. So this is called as secondary amenorrhea. What are the causes of secondary amenorrhea? That is pregnancy, stress and illness. So the pregnancy, it is the most common cause of secondary amenorrhea. So whenever you come across a patient of secondary amenorrhea, you have to rule out the pregnancy, as pregnancy is the most common cause for the secondary amenorrhea. Now the major causes of secondary amenorrhea, it is broadly categorized into 4 compartments, likewise in primary amenorrhea. So here we will be discussing the major causes of secondary amenorrhea in a compartment wise. So the causes of secondary amenorrhea is classified into 4 compartment basis, that is causes of secondary amenorrhea. So it is categorized into 4 compartments, that is compartment 1, compartment 2, 3 and 4. So compartment 1 consists of the uterus, compartment 2 consists of ovary, compartment 3 consists of pituitary gland, while compartment 4 consists of hypothalamus. So now, what are the causes of secondary amenorrhea which are related to uterus? The first one is, that is called as Asherman Syndrome. So Asherman Syndrome, it is also called as uterine synechia, and it is also called as Fred syndrome. The another cause is acquired obstruction of tract, now moving toward the second compartment, what are the ovarian causes? That is Polycystic Ovarian Syndrome, which is also called as Steen-Leventhal Syndrome. The another cause is ovarian tumors. The other cause is, that is surgical removal of ovaries. Surgical removal of ovaries. Also radiotherapy and some sort of infections of ovary like in TB. So what are the ovarian causes? That is Polycystic Ovarian Syndrome, which is also called Steen-Leventhal Syndrome, ovarian tumors, surgical removal of ovaries, radiotherapy and infections of ovary like in TB. What are the causes of secondary amenorrhea related to pituitary gland? The first one is, that is Pituitary Adenomas. Pituitary Adenomas, it consists of hyperprolactinemia, also it consists of Shihan Syndromes, which is also called postpartum pituitary gland necrosis. So the causes related to pituitary gland are pituitary adenomas, hyperprolactinemia, Sheehan Syndrome, which is also called postpartum pituitary gland necrosis. And what are the causes of secondary amenorrhea related to hypothyridism? It consists of excessive weight loss, it consists of exercise, it consists of emotional stress, anorexia nervosa, also bulimia. Bulimia is a psychological disorder in which person eat too much and actually person has lost the sense of control over the eating. So this is called as bulimia. And also it consists of granulomas in hypothalamus, and also it includes the tumors and traumas, etc. So what are the causes of secondary amenorrhea? It is broadly categorized into 4 compartments. In the compartment 1 there is Asherman Syndrome and acquired obstruction of tract. In the compartment 2 there is Polycystic Ovarian Syndrome, ovarian tumors, surgical removal of ovaries, radiotherapy and infections. While in compartment 3 it consists of Pituitary Adenomas, Hyperprolactinemia and Sheehan Syndrome. In the compartment 4 there is excess of weight loss, exercise, emotional stress, anorexia nervosa, bulimia, Granoloma, tumors, traumas. So these are all included in this category, and these are all lead to the secondary amenorrhea. So in all these conditions, actually the release of G and RH is affected from the hypothalamus, which often lead to the secondary amenorrhea. So what are the other generalized systemic causes for the secondary amenorrhea? The other generalized systemic causes of secondary amenorrhea, so that are hypothyridism, it consists of diabetes and chronic liver diseases, chronic renal diseases and anemia and HIV. So the other generalized systemic causes are hypothyridism, diabetes, chronic liver disease, chronic renal disease, anemia and HIV. So students, this is what we need to know about the causes of secondary amenorrhea in a compartment wise. Now let's discuss the compartment 1, which contain the uterus, the main uterine cause which lead to secondary amenorrhea, that is called as Asherman Syndrome. Now let's talk about the Asherman Syndrome. What is Asherman Syndrome? Asherman Syndrome is also called uterine synechia. It is also called as Fred Syndrome. Now what is Asherman Syndrome? So let's define the Asherman Syndrome. So Asherman Syndrome, actually it is an acquired condition in which endometrial lining of uterus is destroyed, and because of this disruption of uterine endometrium, it leads to the formation of intrauterine adhesions, which is also called as a synechia. So these scar tissue, it makes the uterine wall more rigid and decrease the size of uterus, and actually it often decrease the rate of menstrual flow as well. So in Asherman Syndrome, it is an acquired condition in which endometrial lining of uterus is destroyed. So in Asherman Syndrome, the endometrial layer is injured. As you know that uterus consists of 3 layers: premetrium, myometrium and endometrium. Even in certain cases, it is documented that the myometrial involvement can occur in this condition, but they are so much rare. Usually the endometrial layer is destroyed. So as a result of endometrial layer destruction, there is a formation of intrauterine adhesion, which is also called as a synechia. Now, what are the causes of Asherman Syndrome? So the causes of Asherman Syndrome, it consists of postpartum curata. The major cause is postpartum curata and dilatation and curettage. Also, it consists of missed abortion, hydatiform mole, and Also, it consists of the causes chronic infections. And the chronic infections, there could be TB infection like tubercular endometritis, and often schistosomiasis. And certain operative procedures like an C-section, myomectomy, and radiotherapy, and infections and reproductive organs. So these are all are considered as the major causes for the Asherman syndrome, but the most important cause of Asherman syndrome are postpartum curata and dilatation in the carotid. So you should not forget these two causes of Asherman syndrome. So what are the presentations of the patients? What are the presentations of patients of Asherman syndrome? Is in these patients the endometrial layer is usually destroyed. So because of the disruption of endometrial, patients usually complain of amenorrhea, hypomenorrhea, and infertility and recurrent abortion. Usually patient presented with the recurrent abortion. So it is when the patient usually presented with the manifestation of amenorrhea, which means the absence of menstruation. Hypomenorrhea means as you know that normally the menstrual bleeding occur and it is continue from 2 to 5 days. So but in hypomenorrhea the menstrual bleeding continue less than 2 days. So this is called hypomenorrhea. And also patient presented with the infertility. Now what are the investigations for Asherman syndrome? So for the investigations for Asherman syndrome consist of hysteroscopy, that is hysteroscopy and hysterosalpingography and saline sonohysterography. Even you can go for MRI. So what are the diagnosing condition for Asherman syndrome? The first one is hysteroscopy. Actually in hysteroscopy condition we introduce the endoscope into the female uterus in order to visualize the synechia, and this hysteroscopy it is considered as an investigation of choice. The reason is because it is diagnostic plus therapeutic, while in another hand if we talk about hysterosalpingography, actually in this condition we introduce the radio opaque dye into the female uterus in order to find out the in order to visualize the synechia with the help of X-ray, and it usually gives the appearance of honeycomb. But the important point is that this hysterosalpingography it is not the investigation of choice in the Asherman syndrome. The reason is it is only diagnostic and it is not therapeutic. So this is important. Now what are the treatment options for the Asherman syndrome? So the treatment option is hysteroscopic adhesolysis followed by IUCD insertions or balloon catheter. So let's suppose this there is a uterus and there is a formation of synechia. So what happens? Let's suppose this is a uterus. Now let's suppose this is a uterus. Now in the Asherman syndrome the endometrial layer is destroyed. As a result of this there is a formation of intrauterine adhesions, which is also called as synechia. So how you will treat the patients? Initially you have to break these intrauterine adhesions. First you have to break these intrauterine adhesions or synechia. After that you will insert a balloon. And why it is so? In order to reduce the risk of further adhesions or synechia into the surrounding areas of the uterus. So first you will break the adhesions, after that you will insert the balloons so that to minimize the further adhesions around the area of these existing adhesions. So after that we can insert the intrauterine balloon catheter as well. Now as there is the involvement of endometrial, as the endometrial layer is destroyed in Asherman syndrome, so you can give the patient cyclical estrogen and progesterone. And why it is so? In order to promote the reepithelialization of endometrium. So it is worth noting in what is Asherman syndrome. Here there is the destruction of endometrium. As a result of that there is a formation of adhesions. The patient, what are the causes of Asherman syndrome? That is postpartum curita and dilatation and carotid. How the patient presented with you? Amenorrhea, hypomenorrhea and infertility. How you will diagnose the patient? You will diagnose the patient by hysteroscopy, hysterosalpingography, saline, sono, hysterography and MRI. But the hysteroscopy is the investigation of choice. The reason is it is diagnostic plus therapeutic, while hysterosalpingography, it is not the investigation of choice because it is only diagnostic, it is not therapeutic. How you will treat the patient? By hysteroscopic adhesolysis followed by IUCD insertion. Hopefully students, you will get this lecture of Asherman syndrome. So this is what we need to know about Asherman syndrome. So now after that we will be moved toward the second compartment, that is compartment 2. So now let's discuss the compartment 2. So in the compartment 2 there is, so now let's talk about the compartment 2. So compartment 2 consists of the ovary. So what are the main ovarian cause for the secondary amenorrhea? That is Polycystic Ovarian Syndrome. That is called as Polycystic Ovarian Syndrome, which is also called as Steen-Leventhal Syndrome. Now how you will properly define the Polycystic Ovarian Syndrome? So PCOS, it is a heterogeneous condition. It is heterogeneous condition characterized by menstrual irregularity, hyperandrogenism, obesity, and many cysts in ovary on ultrasonographic picture. So how you will define polycystic ovarian syndrome? It is a heterogeneous condition characterized by menstrual irregularity, point number 1, and the point 2, it is characterized by hyperandrogenism. Also it consists of ovary and many cysts in ovary on ultrasonographic picture. So these are the hallmarks of the PCOS, that is menstrual irregularity, hyperandrogenism, obesity and many cysts on ovary. Now what is the most common age group in PCOS? So the most common age group in PCOS are 15 to 25 years. So it means it is more common in the young females. Now in PCOS the main problem is more production of the androgen. So in PCOS there is excessive production of androgen, excessive production of androgens from ovary. Now these androgen, it consists of free testosterone, or it consists of dihydroepiandrosterone or androstenedione, but usually it consists of the free testosterone. So there is overproduction of androgen from ovary. These androgen are usually free testosterone, dehydroepiandrosterone, and androstenedione. Now the overproduction of these androgen or hyperandrogenism, it can create two issues, it can create two problems. Either it can cause hirsutism or it can cause virilization. So virilization means the development of the exaggerated masculine characteristic. So in the virilization, it consists of clitoromegaly, deepening of voice, and alopecia. So the hyperandrogenism, it creates two issues in these patients. It can cause hirsutism and it can cause virilization. So hirsutism means excessive male pattern hair growth. So, and what is the most common cause for of hirsutism in young female? That is a PCOS. So the most common cause of hirsutism, in young female, that is a PCOS, that is Polycystic Ovarian Syndrome. And what is the most common cause of rapid onset hirsutism? The most common cause of rapid onset hirsutism that is not a PCOS, rather it is consists of testosterone secreting tumors of the some ovaries. So hirsutism is excessive male pattern hair growth. The most common cause of hirsutism in young female are PCOS, while excessive production of androgen in rare cases it can cause virilization, like it cause clitoromegaly. Clitoromegaly means the abnormal development of the abnormal enlargement of the clitoris, and it can cause deepening of voice. It can also lead to alopecia, means loss of hairs. So these are the problems. Now the overproduction of androgen in female, it convert into the estrogen. Now the overproduction of androgen in female's body, it convert into the estrogen. So let's discuss the point. The overproduction of androgen in female body, it convert into the estrogen. Now in PCOS, already we know that there is more level of androgen. So it means if there is more level of androgen, so the conversion of androgen into estrogen is more. So if there is more androgen, there is more conversion of androgen into estrogen. So indirectly there is more level of estrogen. Now this high level or excess level of estrogen, it can lead to the endometrial hyperplasia, or it can lead to endometrial carcinoma. Now in normal menstrual cycle, as you know that estrogen has negative feedback on FSH. It has negative feedback on FSH, while it has positive feedback on LH. So in normal menstrual cycle, estrogen has a negative feedback on FSH, it has positive feedback on LH. So in PCOS there is more level of estrogen. If there is more level of estrogen, it means the FSH level will be low as compared to the value of LH. so the LH will be more. So if you see the ratio of FSH and LH in the condition of PCOS, so the FSH value will come always less than the value of LH. So this is important. Now there is another point. As you know that in normal menstrual cycle, the cause of ovulation is LH surge. Normally, the cause of ovulation is LH surge. Already you know it very well. But in PCOS, what happens in PCOS? The LH is constantly raised. LH is constantly raised. What does it mean? It means there is no LH surge. If there is no LH surge, it means there is no ovulation. If there is no ovulation, this is called as anovulation. So there is anovulation. Because of this anovulation, the level of progesterone is decreases. The level of progesterone is decreases. Once the level of progesterone decreases, the Graafian follicle, it converts into the cyst. So there are multiple cysts formed, and that's the reason this is called as a polycystic ovarian syndrome. Means there are multiple cyst formation in the ovary. Now these cysts are arranged around the periphery of ovary and give it to the necklace appearance. So this is important. Now because of this anovulation, usually female has a complaint of the infertility. Because of anovulation, female complain of infertility, and the moment you give ovulation inducing drugs like in the form of clomiphene citrate or letrozole or GnRH analogs, the infertility condition is easily cured. So the infertility is easily treatable in the condition of PCOS. Now this is also important. Now as you know that in this condition in PCOS, there is hyperandrogenism. There is more level of the androgens. There is a very high level of androgens. The high level of androgen, it can lead to another issue as well. It can lead to endometrial atrophy. It leads to endometrial atrophy. And because of this problem, usually the patient came with a complaint of oligomenorrhea, and also patient came with a complaint of dyslipidemia. Dyslipidemia means there is more level of LDL and there is low level of HDL. If it lead to dyslipidemia, it means the future problems will be, yes, coronary vascular diseases. Coronary vascular diseases. So what are the future problems in this condition? The future problems are, that is endometrial hyperplasia or endometrial carcinoma. Also it can lead to the coronary vascular disease. So these are the future problems in the patients of PCOS, that is endometrial hyperplasia or carcinoma, or it can lead to the coronary vascular diseases. Now there are certain other manifestations of the patient as well. Some features are obesity. Some other features are obesity and insulin resistance. The other manifestations are obesity and insulin resistance. This insulin resistance lead to hyperinsulinemia. Hyperinsulinemia. Now this hyperinsulinemia, it can lead to the diabetes, and also it lead to the another problem that is called as acanthosis nigricans. Acanthosis nigricans. So what is acanthosis nigricans? Actually it is a skin condition where there is it causes the dark discoloration in the body, folds and creases. So acanthosis nigricans are the skin condition that causes dark discoloration in the body, creases or folds. And usually the dark pigmentation, they are usually appear on the axilla, groin and neck area. So the other features are obesity, insulin resistance. Insulin resistance lead to hyperinsulinemia. Hyperinsulinemia in turn lead to the diabetes and acanthosis nigricans. Now, what are the chronic consequences of the PCOS? Or we can say, what are the long-term consequences of the PCOS? Now, the long-term or chronic consequences of PCOS. So that are, the first one is endometrial hyperplasia, endometrial carcinoma. Also it can lead to the it can lead to the coronary vascular diseases. Also it can lead to diabetes and metabolic X syndrome. So the chronic or long-term consequences of the PCOS consist of endometrial hyperplasia plus carcinoma, and it can lead to coronary vascular diseases, diabetes and metabolic X syndrome. So there is another question, which kind of syndrome is more associated with the PCOS? So there is a specific syndrome by a name that is called as Sheehan Syndrome. Sheehan Syndrome. So it is more associated with the PCOS, where HS stands for the hyperandrogenism. It means there is more level of androgens, and IR stands for insulin resistance, while AN stands for acanthosis nigricans. So it is the only syndrome which is associated with the PCOS, characterized by hyperandrogenism, insulin resistance and acanthosis nigricans. So students, this is what we need to know about the PCOS. Now let's talk about the diagnosis of PCOS, that how you will diagnose the patient of a PCOS. Now, for the diagnosing of PCOS, there is a specific criteria which we need to know, and that is called as Rotterdam's criteria. So, how you will diagnose the patient with a PCOS? So, there is a specific criteria that is called as Rotterdam's criteria. Rotterdam's criteria. So if you want to label the patient with the PCOS, so it is important that out of 3 criteria, the 2 criteria must be fulfilled by a particular patient. So what are the 3 criteria? The first criteria are anovulation. So it consists of like oligomenorrhea, there is amenorrhea, and all of these things. So the first criteria is anovulation. The second is physical or biochemical indication of increased androgens, or simply we can say hyperandrogenism. And the third criteria is many cysts in ovary on ultrasonographic picture. So the 3 criteria are, the first one is anovulation, the second one is physical or biochemical indication of increased androgens, or we can say hyperandrogenism, and the third criteria is many cysts and ovary on ultrasonographic picture. So if you want to label the patient with the PCOS, so out of these 3 criteria, the only 2 criteria must be fulfilled by the patients for the PCOS. Now this is the diagnosis. Now let's treat the patient of PCOS. So what are the treatment options of the PCOS? So treatment option of the PCOS is depending upon the problem of the patient, that at which problem usually the patient is presented to you. So let's suppose if a patient came to you with a complaint of obesity. So what is obesity? Obesity means having BMI more than 29 kilogram per meter square. So if a patient came with a complaint of obesity, then at that condition you have to treat the patient by lifestyle modifications. Also, you will convince the patient to do moderate exercises and weight loss. So for the obesity, the treatment options are lifestyle modifications, moderate exercises and weight loss. So let's suppose if a patient came with a complaint of infertility. So if a patient came with a complaint of infertility, then you can give ovulation inducing drugs. And what are ovulation inducing drugs? That are clomiphene citrate. It also consists of letrozole and GnRH analogs. Now, if the patients came with a complaint of the irregular menstrual cycle, so in that condition you will give oral contraceptive pills for 21 days, and also you will give medroxyprogesterone acetate 10 mg in last 4 to 5 days of her cycle. So if a female came with a complaint of irregular menstrual cycle, at that condition you have to provide oral contraceptive pills for 21 days and also give medroxyprogesterone acetate, which has least androgenic activity, that is given in a dose of 10 mg and last 4 to 5 days of her cycle. Now if a female came with a complaint of hirsutism, so in that condition you will give combined oral contraceptive pills. Now in combined oral contraceptive pills, there are two components of it, that is estrogen component and progesterone component. Now the estrogen component of combined oral contraceptive pills, it increase the 6-hormone binding globulin level. It increase the level of 6-hormone binding globulin. Now this 6-hormone binding globulin, it combined with the free testosterone, and it lead to the after that the testosterone level is decreases. So the estrogen component of combined oral contraceptive pill, it increase the 6-hormone binding globulin level, and in turn it combine the free testosterone and often lead to the decreased level of testosterone. And also the estrogen component of combined oral contraceptive pills, it inhibit the 5-alpha reductase. And what is the main function of 5-alpha reductase? It convert the testosterone into dehydrotestosterone. So when estrogen component inhibit the 5-alpha reductase, so the testosterone can't convert into dehydrotestosterone, and turn the level is decreases, while the progesterone component of combined oral contraceptive pills, it decrease the level of LH. Now here usually the progesterone that is given, that progesterone are newer progesterone means they have a least androgenic activity. Here the progesterones are desogestrel and also gestodin and drospirenone and norgestimate. They are given. So for hirsutism, you have to give the combined OCPs. In the estrogen component of OCPs, it increase the level of 6-hormone binding globulin that combine with the free testosterone and decrease the level of testosterone. Also, it inhibits the 5-alpha reductase. While progesterone component of combined OCP, it decrease the level of LH. And the progesterone that are given in this condition that are newer progesterone in the form of desogestrel, gestrodin, drospirenone, and norgestimate. Now, also we can give the GnRH analogs. This GnRH analogs, it decrease the level of FSH and LH, and ultimately it decrease the level of androgen. But the problem is, if you give the GnRH for a very longer period of time, then it can create certain side effects in the form of postmenopausal symptoms, like there will be hot flashes to the patient, there will be osteoporosis and all those symptoms. So you can't give it for a very longer period of time because of their lot of side effects. Now, if a patient came with a complaint of insulin resistance, so in that condition we can give metformin. So the metformin in that condition is the drug of choice. So students, this is all what we need to know about the PCOS. The PCOS, the definition, their general characteristic features, and what are the diagnosis, and at the last what are the treatment options in this condition. So the PCOS are the most common ovarian cause for the secondary amenorrhea. So student, that's all about the second compartment. So let's shift toward the third compartment, and third compartment consists of pituitary gland. So there are certain causes of secondary amenorrhea which are related to pituitary gland, that are pituitary adenomas and hyperprolactinemias. So in the compartment 3, it consists of pituitary gland. What are the causes? That are, the first is pituitary adenomas and hyperprolactinemias and Sheehan Syndrome. Sheehan Syndrome, which is also called postpartum pituitary gland necrosis. So let's talk about pituitary adenomas. So what is pituitary adenomas? Pituitary adenoma are the benign tumor of the pituitary gland. How you will differentiate the pituitary adenoma from pituitary carcinomas? Because of due to the lack of mitosis and lack of invasions. So actually, the radiologist usually classify the pituitary adenomas on the basis of its size. So the pituitary adenomas, it is classified into two groups: the pituitary microadenomas and the pituitary macroadenomas. So pituitary microadenomas, these tumors having a size of less than 1 centimeter, while pituitary macroadenoma, in this condition the tumor has a size of more than 1 centimeter. And these pituitary microadenomas, it has a 5% potential to proceed toward the pituitary macroadenomas, and it has a 30% potential to resolve spontaneously. So what is the most common pituitary adenoma? The most common pituitary adenoma are prolactinomas. That is prolactinoma. What is prolactinoma? Here it is a tumor of prolactin where the prolactin secretion is elevated from the normal range. So in this condition, usually the patient came with a complaint of the galacturia and infertility. Also amenorrhea. So the most common pituitary adenoma are prolactinomas, and it is usually patient manifested with a galacturia and infertility. Now usually the pituitary tumors often lead to cavernous sinus features of cavernous sinus syndromes. What are the cavernous sinus features? That are headache, that are blurring of vision, and galacturia. So the cavernous sinus features are, what are the cavernous sinus features? That are headache, that are blurring of vision, and that are galacturia. So on X-ray of sela there is space occupying lesion, and the condition is usually confirmed by the MRI. How you will treat the patients? So what are the treatment options? So if there is pituitary microadenomas, and there is no symptoms to the patients, mean there is asymptomatic condition. So at that condition you have to wait and watch, and you have to wait and put the patients on regular follow up. Also you have to check the serum prolactin level and do MRI after every 12 months. So if there is pituitary microadenomas and the patient is having they are having no symptoms, so in that condition you have to put the patient on regular follow up, and you have to assess the level of serum prolactin levels and do MRI after 12 months. Now if there is microadenomas, if there is pituitary microadenomas and patients are symptomatic, so in that condition you will treat the patient by a bromocriptine and cabergoline. If there is pituitary macroadenomas, so in that condition you will also provide bromocriptine and cabergoline. And if the patient is not showing response to the medication, then at that condition you can go for the surgery. So the treatment option, if there is microadenoma and there is no symptoms to the patients, then you have to put the patient on regular follow-up. Also you have to assess the level of serum prolactin level and do MRI after every 12 months. If there is microadenoma and patient is usually symptomatic, so in that condition you will provide medication in the form of bromocriptine and cabergoline. And if there is pituitary macroadenomas, then you can give with the same treatment like bromocriptine plus cabergoline. While if the patient is not show any response in that condition, so then you can go for the surgery. So students, this is what we know, this is what we need to know about the pituitary adenomas. Now what are hyperprolactinemias? So hyperprolactinemia is another important cause for the secondary amenorrhea. In hyperprolactinemia, the serum prolactin level is elevated from the normal range. Here the serum prolactin level is elevated from the normal range. It is more than 20 ng per ml. And what are the causes of it? There are several causes of hyperprolactinemias, like there are certain physiological causes for hyperprolactinemias, and there are certain pathological causes for the hyperprolactinemias. What are the physiological causes? It consists of pregnancy and it consists of stress. So pregnancy, stress and nipple stimulation. So these are the physiological causes for the hyperprolactinemias, while the pathological causes include certain drugs. Mostly it include the antipsychotic drugs, and also it include the tricyclic antidepressant as well. So, and also if there is any chest wall trauma to the patients, so it can also lead to the hyperprolactinemia. So now students, let's discuss the important cause of the secondary amenorrhea, that is called as Sheehan Syndrome. So what is Sheehan Syndrome? Sheehan Syndrome, it is also called postpartum pituitary gland necrosis. Now let's discuss Sheehan Syndrome. So Sheehan Syndrome, it results from ischemic necrosis of anterior pituitary gland due to spasm of arterioles supplying anterior pituitary gland. So as you know that pituitary gland consists of two lobes. Pituitary gland consists of two lobes. Let's suppose this is a pituitary gland. It consists of anterior lobe and it consists of posterior lobe. So from the posterior lobe it releases the ADH plus oxytocin, while from the anterior lobe of pituitary gland it releases certain hormones in the form of growth hormones, ACTH, TSH and prolactins. Here we are going to concern with the prolactins. Now in Sheehan syndrome, it actually results from the ischemic necrosis of anterior pituitary gland. So there is ischemic necrosis in this area, while it spares the posterior lobe of pituitary gland. It is due to the spasm of certain arterioles supplying the anterior pituitary gland. So there is spasm occur in the arterioles. Now in Sheehan syndrome, it results from the ischemic necrosis of anterior pituitary gland due to spasm of arterioles supplying the anterior pituitary gland. Actually, what happens during normal pregnancy, the size of pituitary gland, it is more from the normal size, like their size is increased twice. So in that condition there are certain cells which is responsible to make the prolactins. That cells are present in the anterior lobe of pituitary gland. That is called as a electrotrophic cells, which is also called prolactin secreting cells. So whenever the size of during pregnancy, when the size of pituitary gland increases, so ultimately the number of prolactin secreting cells is also increases in that condition. So when there is more number of electrotrophic cells or prolactin secreting cells, so there will be more production of the milk. But the point is that the blood supply in that condition is not more in that condition. Let's suppose in pregnancy, say if this is the normal size of the pituitary gland, so in pregnancy the size of pituitary gland is increases, but the blood supply remains same in that condition. So in another condition, let's suppose in postpartum hemorrhage, what happen in postpartum hemorrhage? In postpartum hemorrhage, already in normal pregnancy condition, the size of pituitary gland is increased and twice, while the number of all prolactin secreting cells, it is also increases, but the blood supply is not increases in that condition. So also pituitary gland is not receiving a proper blood supply. So if there is postpartum hemorrhage, so the blood supply to the pituitary gland is further decreases. Already pituitary gland is not receiving proper blood supply, while in postpartum hemorrhage the blood supply to the pituitary gland is more compromised, it is more low. So in that condition, when it is not receiving proper blood supply, so all the number of prolactin secreting cells, they are not gaining a proper blood supply. So what happens as a result of this? There is ischemia occur. There is ischemia occur, and because of this ischemia, it can lead to the pain hypopituitarism. Pain hypopituitarism. It means the hormones level is decreases in that condition, depending upon the hormones which is going to decrease. So this is all about the Sheehan syndrome. Now in Sheehan syndrome, I will repeat it once again. Normally in pregnancy condition, the pituitary gland size is increase in number, while the prolactin secreting cells also increase in number, but the blood supply is remain same, they are not increased. While in postpartum hemorrhage, the blood supply is further decreased to these areas. So as a result of that, there is ischemic necrosis occur in the anterior lobe of pituitary gland. Now there is a question, why the anterior lobe of pituitary gland is involved in Sheehan syndrome and why it is not the posterior lobe of pituitary gland? So answer to this question is that during parturition, the blood supply is redistributed with the advantage of the posterior pituitary gland and with the disadvantage of the anterior pituitary gland. So all of the arterioles that is lying in the anterior lobe of pituitary glands, when the spasm occur in these area, so the spasm of these arterioles and the anterior pituitary gland, it can defect this lobe, the anterior lobe of pituitary gland. So this is important. While there is another important point. If the 75% anterior pituitary gland is affected, listen, if there is 75% anterior pituitary gland is affected, then it is called as a Sheehan syndrome. But and in another hand, if 90% anterior lobe of pituitary gland is affected, then it is not called as a Shihan syndrome, then it is called as a Simmons disease. So if 75% anterior pituitary gland is affected, this is called as a Sheehan syndrome. If the 90% anterior pituitary gland is affected, then it is called as a Simmons disease. Simmons disease. So what is the pattern of hormones that are affected in Sheehan syndrome? So the first hormones that are affected, that is growth hormone, followed by the LH, FSH, TSH and ACTH. So the pattern of hormones that are affected in the Sheehan syndrome, the first is growth hormones preceded with the LH, FSH, TSH and ACTH. There is another question, which kind of hormone is mainly affected in Sheehan syndrome? So that is a prolactin. So the main hormones that are affected in Sheehan syndrome is the prolactin. Now, what are the manifestations of the patient of Sheehan syndrome? So actually it depends upon the specific hormones that are decreases. Let's suppose if the patients came and they have a low level of prolactins. So in that condition, usually patient will be presented with a complaint of amenorrhea. Also there is increased sensitivity to the cold due to hypothyridism, also loss of libido. While if there is low level of FSH or LS, so there will be sexual abnormalities, and if there is low level of GH or growth hormones, so there will be dwarfism. If there is low level of TSS, so in that condition there will be hypothyroidism. So it depending upon the specific hormones level, if they are decreases. So and how you will treat the condition? By replacing the deficient hormones. So this is what we need to know about the Sheehan syndrome. Now let's talk about the last compartment, that is compartment 4, that is hypothalamus. So what are the causes of hypothalamus? So the causes are excessive weight loss and exercise, emotional stress, anorexia nervosa and Bullimia, Granoloma and tumor.